Hello, everyone. Good evening. My name is Alexis Davis. I'm the social media manager here at RSDSA. I'm joined by Jim Broach, Executive Vice President and Director of RSDSA, and so many guests this evening. I think this is going to be our biggest Facebook Live to date. We are being joined by a previous patient and clinicians from the Shirley Ryan AbilityLab Pain Management Center. So today's guests are very accomplished. I'm not going to read all of their bios in their entirety, but I will add the link to their bios to the chat once I'm done with this intro portion. And you'll also be able to see their headshots and just learn everything about them. So tonight's guests in alphabetical order, we have Diane Amstutz, PhD. Dr. Amstutz has worked as a rehabilitation psychologist for more than 30 years. She helped to establish the adolescent pain management program at the Shirley Ryan AbilityLab 13 years ago. She works with adolescents and their parents as part of the treatment team by teaching pain and stress management tools. Welcome. Next, we have Dr. Benjamin Catholi. Dr. Catholi received his bachelor's degree from Illinois College and earned his medical degree from Southern Illinois University School of Medicine. He is board certified in physical medicine, rehabilitation, and pediatric rehabilitation. Next, we have Dr. Wendy Wurtzel. Dr. Wurtzel graduated from the University of Florida in 2012 with a doctorate in physical therapy. She specializes in working with adults and adolescents with chronic pain and POTS. And I know many members of our community are familiar with POTS. And then last, but certainly not least, for our clinicians, we have Maya Yuen. Maya has over 17 years of clinical experience and has a specialty interest in spine care and treatment of patients with musculoskeletal pain. She is a board certified orthopedic specialist and is certified in mechanical diagnosis and therapy. And tonight's patient is Sarah H. Sarah is a freshman at the University of Illinois, and she has been diagnosed, or she was, diagnosed with CRPS in 2016. And I will, of course, let her tell more of her CRPS journey during the live. Now, of course, please remember that while the information shared here tonight is helpful, please consult a physician or your physician for personalized medical advice. And now, before I turn it over to Jim, I do have a quick announcement. So our next Facebook Live next Thursday, May 20th at 7 p.m. Eastern, will be with Dr. Michelle Gargan about CRPS and mental health for Mental Health Awareness Month. We had a lot of people reach out and say that that is a topic that they really wanted us to have a guest on or to come on to talk about. So we are excited to have her join us. So of course, send us your questions for that live. Jim, any announcements before we get started?
I just wanted to welcome everyone and just say that I'm so excited about tonight that when I first started working for RSDSA, I heard about the Rehab Institute of Chicago, which has morphed into the Shirley Ryan AbilityLab. And two of my most famous and beloved physicians used to work there, Norm Hart and Steve Stanos. So I'm really excited about it. And a number of people in our community have gone through the program, and I hope that we'll learn a lot tonight. Thanks, Alexis.
You all are definitely in for a treat. So as usual, leave your questions for our guests in the chat. We will answer them at the end. And I will also make sure that I include a link to the presentation that's being displayed in the chat so you can follow along. So I'm going to stop speaking because you didn't come to hear me, and I will let our guests kick it off.
Wonderful.
Maya, you're
on mute.
Thank you. I could have sworn I pressed the button. Hi, everyone. My name is Maya Yuen. As Alexis mentioned, I'm the clinical manager and physical therapist here at the Pain Management Center for Shirley Ryan AbilityLab. I am going to start us off, and the goal of our presentation today is really to kind of give you guys a little bit of an understanding of what good quality care is for the treatment of complex pain conditions such as CRPS and other pain conditions, like in general, just what to look for yourself and your family members. And then we'll dive into a little bit specifically of what the Shirley Ryan AbilityLab Pain Management Center does in an effort to kind of familiarize you with that. So the first piece is we're going to discuss the three big pillars of an effective pain management program. Number one is an interdisciplinary approach of utilizing a biopsychosocial model, and we'll get into that a little bit more. And lastly, utilizing evidence-based practice to treat complex pain conditions. I want to go over multidisciplinary versus interdisciplinary care. These two terms are oftentimes used interchangeably, but in fact, they are, there are some important differences when we talk about interdisciplinary versus multidisciplinary care. So a definition of multidisciplinary care is a team of healthcare professionals from different fields who coordinate with each other, but aren't considered to necessarily overlap. Interdisciplinary care, on the other hand, is a team of healthcare professionals from, again, different areas of expertise, but they're working together in a coordinated fashion for a common goal for a patient. The treatment of chronic or complex pain through an interdisciplinary management approach has been well established in the evidence-based scientific literature. So it is definitely considered sort of the gold standard of care for this type of these types of conditions. Diving into it further, I hope you can see my graphics because I spent a lot of time on those graphics. Oh, I'm so sorry, one moment. Here we go. Okay, so important items to take note of in a multidisciplinary approach, each individual clinician will approach the patient with their own perspectives and goals. But the end goal isn't established really until after everyone has seen the patient. Goals may not necessarily be in line with other providers due to the separated nature of this approach. And communication between providers in a multidisciplinary model often occurs at the beginning of the evaluation. On the other hand, in an interdisciplinary approach, a collaborative treatment approach is utilized in which we kind of synthesize everyone's assessments and what one clinician, the results of one clinician's testing actually has an effect on the overall recommendation that the whole team has. An interdisciplinary team will also have dedicated time and infrastructure to communicate frequently with one another, as well as the patient. So the patient is brought into the plan of care, brought into the goal setting. Additionally, an interdisciplinary team will be able to adjust the plan of care quickly because they are in communication with each other so frequently, which will provide a much higher likelihood of improved outcomes. Now, looking into the biopsychosocial model, which hopefully many of you are familiar with, this is certainly a model that's, I think, much more adapted now than decades ago. But essentially, the biopsychosocial model evaluates the integrated whole person. So this model considers the mind and the body together, also in the context of, the social context. So what's important about this model is it recognizes that pain or illness isn't simply a single system explained by biology. It is a process that's much more complex. So when you're seeking care from a provider for any illness, but certainly for complex pain conditions, it is really important that the provider acknowledge and address the dynamic interaction between the biological, psychological, and social components. So here's biopsychosocial. The third pillar that we will discuss that's important is evidence-based intervention. So this includes the interdisciplinary approach, which we discussed. It includes an active approach for the complex pain population, which Wendy will get into a little bit more when she speaks. And then lastly, pain science education. So there's very strong evidence to suggest that pain science education can have an important impact on the recovery of patients with complex pain. So for example, education can have a positive effect on pain rating, disability, movement, catastrophic thinking, pain anxiety, coping, fear avoidance and fear of movement, and healthcare utilization. I think just stop and think about that for a second. Simply learning about your pain, understanding why your symptoms have persisted longer than expected, understanding why you're having the symptoms that you're having. That alone is enough to help your outcomes. I think that's a pretty powerful message. And that's one of the reasons why education, and specifically pain education, is so important for patients with persistent pain or complex pain. So now, I want to tell you a little bit about our program here at Shirley Ryan AbilityLab. As mentioned by Jim, we used to be called the Rehabilitation Institute of Chicago. In 2017, we rebranded and moved into a new research hospital. We are considered a rehabilitation specialty hospital, and we provide care for inpatients, for patients that are in day rehab programs, as well as outpatient. As part of our program, each of our patients are evaluated by a physician and a psychologist upon entry. And together, in an interdisciplinary fashion, the physician and psychologist will make recommendations about our program. And the intensity of the recommendations can vary greatly. They can be, for our adult program, as little as 1/2 day a week for 6 to 8 weeks, or they can be intense. Our more intense version is a 4-week kind of boot camp style program that's 5 days a week for 7 hours a day. In our pediatric program, the recommendations tend to stay pretty similar. It's 1 to 2 half days a week. And both of those are going to be a combination of one-on-one treatment as well as groups where appropriate. At the Pain Management Center at Shirley Ryan AbilityLab, our team has a weekly team conference where we're able to assess the progress of our patients frequently, and that allows us to make adjustments as needed. It's important for us in our program to have inclusion of psychology, biofeedback, physical therapy, occupational therapy, vocational counseling, and our nurses are part of our interdisciplinary team as well. Our clinicians have expertise in complex pain conditions. They've seen a lot of different conditions. They've had a lot of experience working with different populations. And so we're really lucky to have a group of clinicians that specialize specifically in complex pain conditions. We do utilize an active approach, and Wendy will go over that again, but essentially that means you're doing most of the work as the patient versus having the work done to you. And we do focus on a lot of education, empowering patients to have the knowledge that they need to recover. So now I will turn it over to our physician, Dr. Catholi, who is one of our pediatric pain physicians here at Shirley Ryan AbilityLab.
Good evening. So I think one of the important things that kind of the physician role, and as Maya mentioned, I'm primarily pediatric focused, but we do have adult and pediatric physicians as part of the pain program. I think often we receive referrals in terms of kind of clarifying a pain diagnosis, and I think that that's an important part of a rehab physician's role in the program, and also kind of reviewing evidence-based approaches with patients, because families will come with a lot of information or questions from therapists, other healthcare providers, or other parents or families. And so I think it's very important to be able to answer those questions. But I also think it's important to really look at comprehensive medical management and rehab management in the short and the long term, because patients may have ongoing needs after they complete treatment with our center. So we're really focused on a family-centered approach here, and as Maya mentioned, kind of interdisciplinary care to really support patient recovery. So I will pass it off to the next person.
Thank you. So in terms of psychology, I think that again, we're very much a part of that interdisciplinary team, and we, I think, rely on the feedback of the therapist as well as we try to give the feedback in terms of coordinating the care that we provide. So we do a lot of cognitive behavioral therapy, helping people recognize thoughts that they're having about their pain that might be unproductive. We do look at thoughts, beliefs, and attitudes. The idea is that no one is going to think about their pain as wonderful and fantastic, right? But we often have thoughts about pain that are really unproductive and that can actually be harmful. It's terrible, it's awful, it's horrible, I can't stand it, I'm never going to be any better, I can't do anything I want. And those kinds of thoughts can stop us in our tracks, right? Those thoughts can lead to negative feelings, behaviors that are unproductive, and no one wants pain. No one runs toward pain, and we're not suggesting that you would, but what we're saying is, how can you talk to yourself in a way, how can you think about your pain in a way that might be more productive, that might be actually helpful? And in working with pediatric patients, and I actually have started using this with adult patients, I always talk about being a good coach. Right? No one likes to be coached by someone who's yelling at them and saying, you're terrible, you can't do this, you're never going to get it right. But yet, when we think about pain unproductively, we're really coaching ourselves in a very negative way. And we want you to start to learn to be able to think about things in a productive way. I don't like this, it kind of stinks, I can handle it, here are the tools I'm learning. So the whole idea of really looking at your thoughts and trying to manage and get those in line with something that's more productive. So again, it says, replacing those maladaptive thoughts and behaviors with more adaptive ones that help you cope, even in a bad situation. So you're going to acknowledge it's a bad situation and that's appropriate, but then you have to say, and here's what I'm going to do about it. So we do a lot, like I said, a lot of cognitive work, and we also do mindfulness. So mindfulness, as you most of you know, is that idea of paying attention in the present moment. We're not very good at that. Most of us are either spending this very moment thinking about something we've done or worrying about something that's going to happen. We're not often in that moment. And by not being in the moment, we miss out on what we're actually experiencing right now. And so we talk about paying attention on purpose, being aware right now, even if it's an awareness of pain, focusing and figuring out how to manage that. So we talk about directing awareness. We also talk about like grounding tools and things that you can use to bring yourself to better mindfulness. So one of the techniques used, for example, is something we call 5, 4, 3, 2, 1. So if you're really thinking about something or worrying about something in the future or something that happened in the past, come to this moment and think about 5 things you see in your environment, 4 things you feel, 3 things you hear, 2 things you taste or smell, right? Trying to come, using your senses to be in this moment. And in doing that, you can stop those catastrophizing thoughts long enough to be aware in the present moment and then to find ways to cope. So you want to just do the next slide. So what do? We talk about that mind-body connection. Stress is a part of pain management for everyone. So we're not saying that stress caused your pain or that you only have pain because of stress, but we know that stress negatively impacts pain. So we talk about the mind-body connection. We talk about how stress impacts the body and discuss the things that you can do to start to manage that stress. So we teach those coping skills. We talk about emotional regulation, on a self-awareness of how we're responding to others and how we can manage that effectively. Cognitive restructuring is that idea of thinking about things in a way that's productive rather than unproductive. We do provide relaxation training, and some patients receive biofeedback, which is actually being hooked up to get feedback about your body and how it's working. We provide everyone with relaxation training, focused breathing, progressive muscle relaxation, imagery, and other tools that will help you get control of tension and then later give you a sense of control of your pain. And we also provide family education for both pediatric and adult patients. It's important for your family to understand and to understand how they can help. And how they can help is sometimes by helping you focus on function rather than asking continually about your pain, asking about your function, asking what they can do to help you problem solve rather than sort of sometimes just focusing on pain. So we obviously touch on a lot of different things and a lot of different roles. With our CRPS patients, we talk about what are your stressors, and then we try to individualize the program. So if we're working with somebody like Sarah, who's a college student, what are those stressors? How do we manage those? If we're working with an adult who has small children or maybe adult children that are stressful, if there are, whatever the issue is, if it's a work-related situation, we try to help identify and then manage those stressors more effectively.
Hi, everyone. I'm Wendy. I'm the physical therapist, and I'll be speaking a little bit to physical and occupational therapy. As Maya mentioned, we have a very active treatment approach in our program, meaning that we are teaching you the tools, techniques, exercises that you can do independently reproduce outside of the clinic. And so more passive treatments, modalities, heat, ice, massage, they're not wrong, but they're just not part of our philosophy and also just not as evidence-based. So we are focusing on these active strategies. You'll be empowered to be able to do these things for yourself. And they also more directly target those changes that we are hoping to make in our body and in our nervous system. And so that's what I'll be speaking to first. Related to physical therapy. In our program, physical therapy is targeting specific exercise to improve your function. What do you need to improve in terms of strength, flexibility of your muscles or your nerves, your endurance in order to move easier and just more optimally throughout your day? Even though we know that for some people, their symptoms might be in a very specific region of your body or a very specific limb, we're still looking at you as a whole person, head to toe, when we form our treatment plan. And so that kind of addresses a little bit more of the physical aspect of things. And then in terms of addressing more of our nervous system and those changes that can occur with CRPS, that's a little bit more specialized and something that we're very familiar with here. So the photo that you see here, we call this the homunculus, and this is essentially a map in our brain, and we have one map for our sensory system and one map for our motor or movement system. And so this map in our brain, in areas where we feel more sensation, like our face, for example, this takes up a pretty large portion of the map. In areas that have maybe more movement or fine-tuned movement, like our hands, this also takes up a larger region of the map. And in more chronic pain conditions such as CRPS, that can result in these sensory and motor maps being a bit more smudged. So we may not have as accurate sensory information coming in or out. We may want to move a certain part of our body and just feel like that connection doesn't really exist anymore, or it's kind of challenging to access that connection. So some of our other treatments are a little bit more specific to target this, such as what we call localization training. So this is an intervention that we use to improve the accuracy of that sensory part of the homunculus. And so this is an example of an actual patient that we had with CRPS. And you write numbers 1 through 6 on the individual's body with a pen or a marker. And then the clinician lightly touches each of those numbers with a pen cap, says the number out loud, and then picks one at random. And it is your job to try to guess what number I picked, what number I touched at random, without looking at that body area. And so we go through this training. Our goal is to get folks more accurate because, again, going back to that homunculus photo of that map, that's going to allow your body to become more accurate with discerning what specific area is being touched and even what that sensation feels like. Because very often pain has become the predominant sensation that we're feeling. And so to discriminate between, is this a light touch? Is this more of a pinprick? That can be something that we retrain the brain. Occupational therapy, I'm actually going to spend even a little more time talking about OT. So our occupational therapists are focusing on that person's ability to participate in their roles, whatever that is, a homemaker, a student, someone who's retired, whatever your job may be. So they're also focusing on the more physical aspect of things like pacing, posture, body mechanics, ergonomics, and some of the more unique interventions are focusing on the nervous system and affecting those changes there. We use a lot of desensitization, braided motor imagery, and mirror therapy. Desensitization involves providing some sensory input to the affected area to decrease that sensitivity to that input, to that touch. So for example, OT might have a patient gently apply lotion to that body area for a few minutes as part of their kind of home program to decrease that sensitivity to touch. And then as the treatment is progressed, they may change it to a more uneven surface, like using a towel to rub against your arm. Graded motor imagery. This is the process of imagining your body doing a certain movement in order to retrain your brain and kind of access those movement patterns again. So it's helping to wake up this part of your nervous system and, again, retraining that movement or motor part of the homunculus. So for example, if your symptoms are in your hand, we might have you visualize gently moving your fingers as we monitor your symptoms, your pain response, maybe any color changes or temperature changes. And mirror therapy, which you see in this photo, is a bit of a progression of graded motor imagery as a way to begin seeing the movement. So first visualizing and then actually seeing the movement. So the individual pictured here is using this reflection of her right hand in the mirror to retrain the motor part of her brain to move her left hand. So when she's moving her right hand, for example, if she does start moving her fingers back and forth, even though she's moving her right hand, her brain will really see her left hand in the mirror. And so again, during all of these interventions for physical and occupational therapy, we're also giving that pain science education so that you really understand what each of these different techniques is for, how it's going to have a positive impact for you, and also teach you those tools to know how to manage these symptoms and kind of stay within a therapeutic challenge for your body. We call it a safe and soar challenge.
So hi, my name is Sarah, and I developed CRPS in April 2016 when I was 13 years old. I dropped a 10-pound weight on my left foot, which didn't do any physical damage, but I was in a ton of pain, so I went on crutches. But even as time progressed from the injury, nothing improved in my pain. So my primary care physician recommended physical therapy to try to get me recovered. And during that time, I was able to walk without crutches, though I used a surgical shoe for support. And I wasn't on any serious pain medication at the time. It was only over-the-counter drugs, and I was not diagnosed with any pain condition. But I still wasn't improving. So my physical therapist did suggest that it could be nerve damage because there was no physical issue. I had x-rays and MRIs done. And then in August of that same year, when I was 14, I re-injured my foot by falling, which put me back on crutches, and I was in even more pain at that time. And it was at that time that I was prescribed gabapentin, which is a common drug used for pain management by an ER doctor. And I also started seeing a chronic pain doctor through the Lurie Children's Hospital, who diagnosed me with CRPS. So the whole process was kind of fast. My diagnosis took less than a year, and I'm very, very lucky for that. And I'm very grateful for my parents for getting me the care that I needed. Although that pain doctor only wanted to see me every 3 months and there was no psychiatric help. So it's kind of on my own for the first couple months of high school, which was okay, I guess, but I wasn't really dealing with my pain. And I was kind of just like living with it. And then in October of 2016, I experienced a big flare up of my pain and I was not able to go to school. It was like an 8 or 9 on the scale. I really couldn't do anything. I wanted to go back on crutches. And so my parents thought I needed a more involved program and I needed more active care. And that was when I entered the pain program at the Rehabilitation Institute of Chicago, which is now known as the Shirley AbilityLab. And I met Dr. Revivo, who is still my pain doctor, and I started receiving counseling through Dr. A. My parents liked the program because it was way more involved in my previous ones, and so I did the 2-day program. So I would go into the city 2 days a week. And it was supposed to be 1 day was individual and one was like a group therapy. But actually at the time, at the beginning, I didn't have like a buddy to go through it with. There weren't any other pediatric patients. So it was more so like 2 individual half days. But towards the end, when I was graduating, I did start getting some friends, which helped a ton because at the time I didn't really know anyone with the pain. And being able to talk to other people with chronic pain was very, very helpful. There was a huge focus on stress management and occupational therapy, which really helped because I couldn't really be a student and have a pain condition at the same time because I wasn't going to school. And the focus was getting me back into the classroom because it was difficult for my academics. And I experienced the active physical therapy and all of those tools, which really helped me get back into school and back to normal function of life. But at the time in early 2017, I started to experience very bad anxiety related to my pain, which is common. It was really difficult. I was young and it was very overwhelming. It was all happening really fast. And I had a lot of difficulty going back to school because I wasn't comfortable there and I was still in pain. So I was diagnosed with generalized anxiety and I started seeing a psychiatrist, and my mental health care remains a huge part of my treatment to this day. I still see a therapist every week. I highly recommend it. One of my favorite parts of the RIC program was the psychological care, because that was when I started to really improve, was at that point when I was starting to address the holistic, like how it affected every aspect of my life. Because it really does affect every aspect. And if you're not treating every aspect, then you're not gonna recover. And then I graduated the pain program in the early 2017. And since 2017, I still am in a little bit of pain. My daily average probably like a 1 or 2, which is so much better than it has been. I don't think my function would be any different now. I'm back to full functioning. I go to college. I'm a good student. Like it all worked out for me on that front. And when I do experience bad pain days, I have the tools that I need to be able to handle it. And I rarely miss school anymore for my pain. And I received accommodations and everything. So I received a lot of support academically from my parents and my doctors. And I'm still in treatment for my mental health. There's a huge correlation to mental health and pain. And it's impossible to treat one without the other. They're very intertwined for me. When my pain goes up, my anxiety gets worse. When my pain is better, my anxiety is better. And I really don't think an effective pain program can be effective without mental health treatment, which is why I think this program is so helpful. And as for my pain treatment, I see Dr. Revivo annually or semi-annually, depending on how I'm feeling. And I continue to use the tools that I learned, not just for my pain treatment. I also use it for every time I feel stress, because I mean, it works. And I think it really helped this past year, especially with COVID. It was very overwhelming, but I didn't have any increase in my pain or anything, even though it was a very stressful situation. In large part due to the fact that I was able to use the tools. So I'm very, very grateful for RIC or Shirley AbilityLab for everything, because it was difficult at the beginning before I was seeing them. It's all just like a blur because I wasn't getting the treatment that I needed. And I really needed a more like involved program and a more holistic approach because I didn't receive that to begin with. And I still am on gabapentin. I still use that, and I still do the physical therapy and desensitization, which is very helpful. But all in all, I would say that I'm doing a lot better than I was. And I owe that in large part to the people at Shirley Ryan AbilityLab. And I'm still very grateful to this day for everything that they did for me. So thank you.
Thank you, Sarah, so much. I swear we didn't pay Sarah to say all that stuff. I swear. Thanks so much for sharing your story, Sarah. Really, really appreciate that.
Yeah, of
And
course.
Sarah was such a hard worker in the program too. She was such a pleasure to treat, but she came in with the absolute right attitude of, you know, what do I need to do? What's the responsibility I need to take for this? And I remember her very clearly treating her and just watching her grow and watching her success. She worked really hard. She really gets the credit. We did what we did, but she's the one who put the work in. So
Thank you.
I think at this time, Alexis, we're done with the presentation.
Yes, I am going to bring Jim back on as well and change the view so we can all see each other. All righty, so thank you so much for that presentation. We do have a few questions that have come in, and if you are watching, of course, feel free to leave questions in the chat and we will get to them. So one of the first questions is just about like how long the program is, if there are multiple pieces of the program. I know some people are just kind of wondering if they have to go to Chicago to physically, you know, be in the program. How does that work?
Yeah, I can answer that. This is Maya speaking. I know it's hard to tell with the masks on. Our program is only located here at the flagship hospital in downtown Chicago. Our program can last, if it's intense program, if it's our most intense program, it's about 4 weeks. But we do have a 1-month follow-up appointment with our patients, at which point we assess progress and we can make further recommendations as needed. That's for our adult program. For our adult program, we also have as little as 1/2 day a week, which can extend. Usually it's around 6 weeks. Occasionally it'll extend into 8 weeks. And then for our pediatric program, again, it can be somewhere around 6 to 8 weeks, correct? So that's the length. And unfortunately, we do only have the one location in downtown Chicago.
Another question about what % of your patients have had significant improvement in pain after the program, and about how long does that last?
We actually collect outcomes. We take a lot of psychometric measures, and primarily all of our patients, especially in our full intense program, do see improvements primarily in coping, mood, sleep, physical functioning, and we do see improvements in pain, but our focus is certainly on getting people a better quality of life. I'm sorry, I don't have the numbers on the percentage of patients, but the majority of our patients are seeing improvements, whether they're in our partial program, pediatric program, or adult program.
And then we also have another question about cost. Someone was asking if the cost is covered by private insurance, or if there's any details that you all can share about how someone will be able to come to the center and pay for it.
Yeah, I'll take that one too, guys, unless someone else wants to take that one. It's really variable, and over the years, I've seen it be more and more variable. I know that there are some insurances that, you know, it just really depends on your coverage, where they'll cover most of the program. The out-of-pocket cost, if you were going to pay like the full price for a day, it's about $2,500 a day. If you're really paying out of pocket, we provide we give a reduced rate, which I'm not exactly sure what that is, but it's like close to like 40% or something like that. We know that a lot of the government programs, the Medicaid replacement plans, we take all of those plans. Unfortunately, they don't cover psychology the way that we bill it. We bill it as a health and behavior code, so under the rehabilitation umbrella. So our psychologists aren't billing for depression or anxiety, they're billing for like back pain or CRPS. So there is a little bit of issue with payers in that regard. So that there are certain insurance companies that just don't pay for psychology and don't pay for group therapy, which unfortunately is a large proportion of, I mean, it is our program essentially. So that's pretty unfortunate. And we give resources to those patients to the best of our ability.
We have another question, and I did make sure it was okay. So Sarah, would you be willing to share what dose of gabapentin you're on to sustain you?
Yeah, so I'm on 1200 milligrams right now. I take 2 tablets, 600 milligrams in the morning and afternoon. I was up to 1800, which is like the standard dose, but over time I was able to decrease that.
Jim, do you have any questions? And you're on mute if you do have any. See if I can grab him.
Sorry about that. I would really like to have you speak to people with long-standing CRPS, because a lot of our community has had it sometimes for decades.
Yeah, I mean, from a physical therapy perspective, I would say that as the PT, one of the PTs in this program in general, so many of our patients, whether they're coming because they have a CRPS diagnosis, whatever their diagnosis may be that they've had for a number of years, it is not their first time doing PT. It's probably their 10th or 20th. So really kind of highlighting the aspect of this program, we call it functional restoration. So yes, perhaps you have had your diagnosis or your condition for years. Where are you right now in your life, and what changes would you like to see to, like Maya said, have that better quality of life? So how can we maybe help to support you having more insight into managing your day-to-day symptoms so that you can participate more in what you want to do with your family, your social network, your job. And then also give you tools that will stay with you for the lifespan.
I think another piece too, that we find with patients that have gone to many other specialists for their condition, in particular conditions like CRPS or other kind of neurologically based, like very complex conditions, is this, approach of trying to create neuroplastic changes, not only in the message that we're giving our brain, as Dr. Amstis, was talking about in terms of like the messaging we're providing ourselves, but also the, motor and sensory approaches that we take. And I think that it's definitely not unique to us. It's out there in the literature. It's something that's being done internationally, but unfortunately, it's not an approach that's very common. So we do have the ability to give patients other strategies, other treatment approaches. And a lot of our patients do come in having had a lot of passive approaches: massage, mobilizations, ultrasound, hot packs, injections. So there is, even if a person's had it for many years, there are opportunities to take a different approach.
I want to highlight something that Sarah said too, in terms of the stress pain relationship, right? And really taking care of that and really finding a counselor, a therapist, something that helps you cope with that, because having chronic pain is stressful. There's no question about that. But I think part of what we try to do is help you figure out, how do I manage that minefield of stress, right? What's going to help me function and get through that? So I really appreciate, Sarah, you're highlighting the fact that the counseling has been an integral part of recovery for you, and just kind of keeping you even. And the fact that you started college during COVID and you had a great year and been very successful, I think really, really speaks to the work you've put in doing that.
What about, are there any exclusionary criteria that you have? Some rehab programs won't allow people who are on long-stand opiate therapy to come in. I was wondering, is there, about your program?
Dr. K, you want to take that one?
Yeah, I would say that we don't, you know, in terms of different programs throughout the country, I think some are very in favor of non-medication based approaches. And I think we try to meet people at their level, you know, and what their needs are. I think some patients are not ready to come away from medications, but we're not opposed to, you know, I would say that in general, we're a non-interventional program, meaning we don't target a lot of injections or procedures, but we are open to complex medication management because I think that everybody's pain is their own, and we can't apply a single approach to a broad population.
I think that's a great answer. The only thing I saw you didn't touch on is the pool. Warm water therapy.
The pool, I know, I did not mention the pool. Yes, we have a wonderful pool here that we love taking our folks into. I mean, just a wonderful place to initiate some movement in an environment where gravity is not kind of there in the same way. The water offloads our joints. We're not necessarily weight bearing in the same way, if that is, you know, more of a challenge on land. So allows us to work on those movement patterns of our walking, of our movements. It helps us address strength and balance training. Yeah, in a really kind of safe and also just fun environment.
And I know with some of our patients that have like very, very high sensitivities, while we're having, you know, pool therapy with a few of the participants, we'll initiate a desensitization plan for them poolside. And that's, you know, especially if it's a goal of theirs, but also just in general for improving, you know, that sensory piece and being able to function in, you know, in the shower and in the bathtub and all those kinds of things. So yeah, we do. It's a very nice pool. We're really lucky to be in the flagship, and it's a really cool, it's a very cool pool that is located on the same floor as our program. So we're very fortunate.
Right. Just a aside, we once did a aqua therapy video at the Hospital for Special Services, and then they filled in their pool. So I'm glad you kept your pool.
Oh, yeah.
I have another question that's similar to your previous statement. So I know a lot of warriors are sensitive to certain smells and allergies. I know there are other centers in the US that, you know, allow, you know, service animals or things. So can you talk about whether or not the center is like fragrance free for those people who have like chemical sensitivities? Are people allowed to bring service dogs? How do you deal with all of those types of things in the center?
I mean, I think in general, we're pretty, we do allow service dogs. We don't get a lot of complaints regarding, you know, odor, light. I mean, we definitely have some of our patients that have, you know, post-concussive type symptoms or other sensitivities, certainly sensory sensitivities, but part of our process is to discuss that as part of our therapy and figuring out, you know, ways to manage that, how, you know, other goals, like if you want to go back to school or you want to go back to work, how are we going to troubleshoot that? So I think when there are obstacles like that, we try to take the approach of, okay, we've identified this barrier or this, you know, challenge. What's a way that we can kind of incorporate that into our intervention and make that part of our goals?
I want to say, Jim, do you have any other questions?
No, I'm so glad you came. We've been working on this for a while, and but I'm so in favor of your program. I would really encourage you, if you haven't done, just publish your long-term study on follow-up. I mean, because there's not many programs like yours out there at all, and should be proud. And I know you are.
Thank you.
And thank you so much for having us. This is a great opportunity.
Definitely, definitely. So, of course, once again, thank you all for this great information. If you are looking to learn more, you can visit them at sralab.org/pain or give them a call at 312-238-7800. That information was also at the bottom of the presentation. So, of course, this was recorded so you can watch it over and get that information. So, as always, we will have this video pinned to the top of our Facebook timeline for easy access until our next Facebook Live. And we're also going to add it to YouTube if you have any friends or family members who are not Facebook users. So we will also add it up there. And we will also add a link to the presentation there as well. And it is in the chat for the Facebook video. So once again, if you have any questions for RSDSA, if you're looking for a support group, if you're looking for a new physician, or maybe you are looking to write for the blog, send us an email at info@rsds.org and we will find a way to get you the information that you need. Thank you all and have a great evening.
Thank you.